Thank you for the introduction, and thank you for the invitation, and thank you to the audience for being here today. And I understand that the audience, we're going to have a combination of people living with the condition, their loved ones, and a smaller amount of individuals who take care of those with the condition. So thank you all. So as mentioned, I'm going to be talking about bipolar depression. And I've been doing research in bipolar disorder, teaching learners, as well as treating patients. And this goes back literally all my professional career, more than 30 years, including now that I have administrative responsibilities. I look after faculty, learners, and make sure that patients receive the best possible care. I continue to provide clinical care to those living with the condition. So we're going to focus today on bipolar depression, as opposed to talking about bipolar disorder in general or talking about bipolar mania. We're going to be talking about bipolar depression. So I'm going to bring my slides. And it's always good to ask, do we see the slides in presentation mode?
Looks good.
Okay, thank you. Well, let's talk about bipolar depression. As you can see on the table here, we have here the prevalence. And prevalence means it's the same as percent, the number of individuals with the condition within a population. So as you can see here, the prevalence of bipolar disorder, if you take all the subtypes, is around 10%, which is close to major depression. The prevalence of major depression is larger. And then some differences. The age of onset is younger in bipolar disorder. And as you can see, it varies within the subtypes. You can see here bipolar 1 and bipolar 2. So what is the difference? The diagnosis of bipolar disorder, you just need to have one episode of mania. If someone has an episode of mania, even without an episode of depression, that is bipolar disorder. What's the difference between bipolar 1 and bipolar 2? In bipolar 2, you have hypomania, and bipolar 1, you have mania. What is the difference between 1 and 2? And actually, that has varied. It is mostly having to do with severity. A key point is in bipolar 2, when there's hypomania, the individual can function, as opposed to bipolar 1. And the depressions, this is another very important point. A depression or a depressive episode in bipolar disorder, it looks exactly the same as major depression. In other words, if I have a patient in front of me and the patient complains of depression, how can I make the differential diagnosis between bipolar depression or what we call major depressive disorder? Others call it unipolar depression. That is, it's a good term. Well, the way to make the diagnosis is if there is an episode of mania or hypomania in the past, that's what makes it bipolar depression. So it is the history of a manic episode or hypomanic episodes. Otherwise, the symptoms are very, very similar. Now, is it important to make the diagnosis? The answer is yes, for two very important reasons. My expertise is pharmacology, not psychotherapy, so I'm going to stay within my area of expertise. So when we talk about medication, treatments that are effective and I'm going to use the term unipolar depression just to be more precise. Treatments effective in unipolar depression, like the regular antidepressants, the Prozac or the escitalopram, Lexapro, those do not have efficacy in bipolar depression. So that's why it is key to make the differential diagnosis. And in fact, in some cases, the use of antidepressants in bipolar depression, main problem is that they don't work. But second, it can exacerbate the symptoms of mania, irritability, and in small cases, it can make the switch to mania. That's actually rare. The most common challenge is finding the right treatment. We have clinics that in general, they're called treatment-resistant depression clinics. And studies have shown that in those clinics, anywhere in the country, about 40% of them are patients with bipolar depression, and they're treatment resistant because they haven't received the right treatment. So that is the importance of diagnosis. Making the diagnosis, if it doesn't help us with the selection or treatment or the prediction of outcome, is not really very helpful. So let's get back to the table that we have here. So the age of onset is younger in bipolar 1. And as mentioned, the difference between 1 and 2 is that bipolar 1, there's a history of episode of mania, and bipolar 2, episodes of hypomania. Now, comorbidities. That term means that in addition to one condition, a comorbidity is another condition. And those comorbidities could be another mental health disorder, in this case, anxiety. So it's very common to have bipolar and anxiety. As you can see in bipolar 1, 87% of the population. Now, the main challenge is the substance use disorder comorbidity. Actually, before the presentation, I was chatting with Mr. Stark about the importance of making that diagnosis. Well, he's the one who pointed out ruling out a comorbid condition, because that affects the outcome of the condition and also the treatment. And a key point is that there should always be a team. In other words, if someone is an expert in treating substance use and another individual is an expert in treating bipolar, they should work together. There's some who are experts on both, but in general, especially with more complicated cases. So it's key to have them in the same clinic, that we like to call them dual diagnosis clinics. Now, bipolar disorder can be a lethal condition. More than 20% of patients actually have attempts, and actually the dying by suicide can be in the teens. So we think about conditions of the cardiovascular or cancer being lethal. Bipolar can also be lethal. So that's why we need to be very careful with the treatments, with the follow-up, and so on. So as you can see, very high substance use. The majority of individuals with bipolar disorders have comorbid substance use, and the majority have a history of attempts. Fortunately, not all attempts lead to a lethal outcome. Now, this is another interesting table, and what we have here is the importance of knowing what was the type of the first episode and what is the course of the illness. So as you can see, blue is depressed, red is mania, and then this is the total. So patients with bipolar 1 have more episodes of depression than mania. Okay. Now, on the other hand, those with mix, okay, you have both, and then all bipolar, you have periods of depression and periods of mania. So that's what's called mixed episodes, and the treatment of episodes is different than that of we can use the term pure mania or pure depression. And mixed symptoms is not rare, unfortunately. Now, so we have in bipolar 1, you have about the same episode of mania and depression. Bipolar 2, actually, there is more hypomania than depression. And mixed, as you can see, still more mania or hypomania than depression. And this is another interesting one. When you have the first episode of depression, there's more episodes of depression than of mania. Now, We mentioned the term called unipolar depression. That's no history of mania and hypomania under different conditions. Actually, a good way to explain that is, let's say we have lower extremities, increased volume. Okay, so that could be caused by problem with the heart or the kidneys. So there's different conditions with the same symptom. Now, in medicine, we know the reason. In bipolar or in psychiatry, we don't. But what I'm emphasizing is that you can have the same symptoms, but at different costs. Okay? So that's why treatments are different. So to what extent patients who were first diagnosed with unipolar depression actually then have a manic episode, and then there will be the next depression will be called bipolar depression. Now, in retrospect, you can call that the first depression was bipolar depression, but it didn't qualify as such until there was a manic episode. So as you can see, it happens. Some studies have shown that up to 8% of individuals who were initially diagnosed with unipolar, then later on they were bipolar depression. And here you can see the rates over 1 year. So within in a population, you have a percent, close to 2%, that will switch from unipolar to bipolar depression. So some generalization or some important points of bipolar depression and how to make the diagnosis. Family history. So let's say I have a patient in front of me who's depressed, and I need to decide the treatment. And I only have one question to ask. That question is, do you have a family history of bipolar disorder? And if the patient does, the likelihood that what I'm seeing is bipolar depression increases. Also, and we're talking about the depressive phase here. So there's an earlier age of onset in bipolar depression than in unipolar depression. Then there's more tiredness in bipolar depression. Postpartum depression, actually, it is more common in individuals living with bipolar disorder than with unipolar depression. So it is key that when there's postpartum depression to identify, is this bipolar depression or not? We have at UNM a service, it's called reproductive psychiatry, that of course addresses issues around the perinatal. And that's not that uncommon, fortunately, to have postpartum depression. So if we don't have a good history, like a family history of bipolar or previous episode of mania, we might not be providing the patient with the right treatment. And we're going to talk about treatments later on. So it's often the postpartum. Mixed states are common, meaning you have an episode of depression, but you also have some symptoms of mania, irritability, racing thoughts, what have you. And you can also have mania with mixed symptoms of depression, which actually the combination or the presence of mixed episodes can be quite lethal, because you have symptoms of mania such as impulsivity. And then you have symptoms of depression like hopelessness. So that's very important when we see a patient, are mixed symptoms present here. And that might, of course, make us take more precautions in terms of risk of self-harm. Then this is another important term. Morbidity means, as the word suggests, the etymology suggests, is being ill. And many times we have patients with bipolar disorder who have mild symptoms. So they're not fully manic or fully depressed, but they have mild symptoms. And it is actually the mild depressions that lead to worse outcomes. Sometimes individuals with mild manias, they can sometimes function quite well. The problem is that it's not consistent. But when there's subsyndromal depressions, there's lack of interest, lack of energy, and so on. As mentioned, high suicide risk when it's mixed. And then antidepressants are overprescribed in bipolar depression. And the problem is that given them alone, they don't work. And sometimes they can cause mania. Are they contraindicated? We'll talk about that a little later. But the take-home message is there are overuse when used monotherapy. So in combination with other medications, and we'll talk about that later, it is appropriate, but in monotherapy, it's not. We prescribers sometimes underuse the combination of the antidepressant and a mood stabilizer or an antipsychotic. And then we always have to talk about cost to society. There's more money spent in bipolar disorder than in unipolar, both in terms of the individual not being able to work or the expenses of treatment. So some of the challenges, there's a lot of residual symptoms, bipolar depression, and those need to be treated, need to pay attention. Another key thing that I've mentioned many times, misdiagnosed as unipolar depression. And then another thing that we've mentioned, very high risk of comorbid conditions. And if you don't treat the comorbid conditions, that affects the primary condition. Let me take a little bit of a segue here. Marijuana was legalized in New Mexico. So if you ask my opinion as a citizen, I would say, well, I think it's good for law enforcement to focus on drug traffickers and in adolescents smoking marijuana. But if you ask me as a provider, it is risky. Studies have shown that adolescents who smoke marijuana, the risk, if they have the genetics, meaning family history of bipolar, smoking marijuana can decrease the age of onset. Okay? And those with the condition, if they smoke marijuana, can actually cause relapse. Now, I have patients who use marijuana, so-called medical use, and they ask me, should I use it or not? My answer is, I am not an expert in the treatment of marijuana. So if it helps you with your anxiety, I believe you. But there are studies that show that it does increase the risk of relapse. So again, from a legal point of view, societal, I think it was fine. But if we focus on, say, what I do, which is treating patients with bipolar disorder, we need to remind patients, and for that matter, when I have parents and patient suffers from bipolar, and they want to ask me, well, is there some preventive measure that we can do with the younger siblings? And one thing that I let them know is make sure they stay away from marijuana or the drugs. I'm just highlighting marijuana because it's the one that is legal. Methadone. Methadone is, in fact, the chronic use of methadone, even if the patient stops using methadone, would lead to a chronic condition that in many ways is similar to a mania. Sometimes in the psychiatric emergency service, we see many patients who have mania and stimulants use. And then we don't know what's causing the condition. Okay, if it's the stimulant or is it the condition, and sometimes it's both. So only time will tell. Again, a lot of disability. What I've mentioned many times, some treatments don't work well, and again, overuse in antidepressants when many times they do not work. Okay, so this we've talked about it before. Patients present with depression. Many times, 23% of them actually have bipolar depression if a good history is not taken. In fact, the majority of bipolar patients who present for care suffer from depression, especially in outpatient care. Most of those with mania present to the hospital or the emergency room. Many patients, the first episode is depression, and then later switch to mania or hypomania. We've mentioned it before. And actually, it's not a small number. It's close to 60%. So this is an interesting graph. So you see, this is the onset, and this is the when the onset was mania, you see that the course is most likely to have manic episodes in the future. And then when the onset is, the first episode is depression, you tend to see more depression in the future. So it's very important, and sometimes we don't do it. We need to take a good history and ask the question, what was the first episode? And especially when we're doing maintenance treatment, and if the first episode was depression, the chances of relapsing to depression are larger than relapsing into mania. So that is an important question to ask that we sometimes do not do. And there's treatments. I mentioned many treatments don't work for treating the acute depression. The same thing happens with preventing depression. So a treatment that works in the acute episode, in general, they work with the prevention, but not always. And there's a number of examples that we will mention. So this is, as I've mentioned, if first depressed, they'll have more depressions later on. And if there's a predominance of depression, the likelihood of comorbid substance use is larger. And we tend to say, well, patients self-medicate when they are depressed. They use stimulants, and when they are high, they use alcohol. It happens, but that's really not the rule. When we see patients with mania, that's when they use the stimulants, not when they are depressed. But there's that tradition of calling self-medication. Yeah, the treatment that has the worst outcome is when it's more depressions because of, again, the inability to function. Now let's talk about maintenance or recurrence. So these are the lithium. Is lithium a good drug? Yes, it is. And it's been around, well, almost a century, 1949. So it's a treatment that's been around for a while. It is not the perfect drug, but I always like to say that every patient has the right to find out if they respond to lithium. Unfortunately, not all patients respond to lithium, but there's a group of patients that when they respond to lithium, they respond very well. So that's when I mean the right. In fact, some genetic studies have shown that in terms of the genetics of response to treatment, the most compelling has to do with lithium. The problem again is that in some cases it doesn't work. It's not the magic drug, but with some individuals it works very well. So here's some important data, and this has to do with a relapse. So lithium. I know the degree of statistics that the audience know. I'm sure some of you know a lot, but some not. So I'm going to try to go to a little bit lower level. So if you see smaller than 0.05, that's considered significant. So as you can see, in terms of the prevention of mania, lithium is quite effective. Unfortunately, not in terms of the prevention of depression. So lithium is good in protecting mania, not as good in protecting depression. So that's when I have to make a decision about what maintenance treatment do I prescribe this individual who's in front of me. And I need a history. What is the predominance of the previous episodes? If the patient or the loved ones tell me depression, then I'll go for depression. And let me talk about the loved ones. When I first see a patient with bipolar disorder, what I always tell them is that in order for me to provide you with the best possible treatment, it is important that I get information of how you're doing with those who know you well. I don't know you well, and they observe you. So a key question is, I'll ask the mother, the daughter, the significant other, how are they doing? Is this their usual self? Because sometimes the patient doesn't know. So it is that collateral information that is key. And it's also key in terms of history, because many times patients do not recall or don't see hypomania as being a condition while the significant other would know, yes, there was a week that you were spending a lot of money and being impulsive, and that was not your usual self. So that's the importance of collateral information. So unfortunately, lithium not great in preventing depression, but let me get back to what I've mentioned a few moments ago. This is in general, because you do have patients who have this condition that is related to responding to lithium, where it can work in the prevention of depression. Okay, but the data that I'm showing here is not in that subpopulation that unfortunately has not been well identified with genetic studies. There's some advances, but I am sure that at some point we will reach the level of sophistication that in oncology, that we can find for this patient, this is the right treatment because genetically the test will tell me so. Although psychiatry is more complicated because not everything is biological. And so it's more complicated than, say, oncology. Well, again, not everything is biological there as well. So let's talk more about treatment. So these are the different medications that have been treated with different drugs. Let me just, I have worked with olanzapine, just so you know. I actually at some point was an industry scientist, so I designed a number of the studies with olanzapine, but just so you know. So olanzapine, in terms of preventing depression, it wasn't that great. Aripiprazole, and we're focusing against in prevention. Aripiprazole, unfortunately, not either. Lithium, we've talked about it. Risperidone, it seemed to be more effective. Let me repeat, in preventing depression. Valproate, quetiapine. Actually, the data for quetiapine are good. The problem is tolerance. It causes weight gain and other problems, but in terms of the efficacy of helping with mania, depression, and prevention, it's probably one of the best data. Lamotrigine is an interesting medication. The FDA approved lamotrigine for the prevention of relapse. But when you look at the data, and we have, you will see that it works well in preventing depression, but it does not work in preventing mania. And sometimes it's also used in the treatment of acute bipolar depression, not effective. There's 4 studies that are negative. Now, if one of you tells me, a provider, well, I have 3 patients that responded great, I believe you. Of course, these are exceptions, so I'm just only talking about data in general. Now, the lamotrigine is, in terms of the prevention of depression, is quite effective. We reviewed clinical trials comparing lamotrigine and lithium, and we identified a very interesting finding that in terms of time to a relapse, I'm well today. How many days will it take for me to have a relapse? Lamotrigine was better. It took longer. But then when you ask, well, when they are having relapse, how are they doing? And those on lithium were doing better, because those on lithium, there was less subsyndromal symptoms. So you see, when you look at prevention of relapse, you also need to take into account in between, how am I doing? And this is a technique that was first studied in cancer. And the obvious question, okay, you want this drug, you will live 1 year. With this other drug, you will live only 6 months. But the question is, will I be able to enjoy that year or those 6 months? And then many times the one drug that makes you survive 1 year, it's 1 year with nausea, okay, or with other side effects. So that's the importance of not only looking the prevention of, but also how are you doing when you have not relapsed. Moving along here, treatments. Let's just review treatments in general. And I do pay attention to the approval by the FDA, not only for efficacy, but also for safety. The data that the FDA has on safety, that's what's in the recommendations by the medication, only applies within that dose. So if you go higher than the dose approved by the FDA, you're getting into territory that is unknown. You can't really tell it is safe because there's no data. So yeah, no, I think the FDA does a good job. So antidepressants in bipolar disorder, we've mentioned it many times. They don't really work. So then when should you not consider them? If there's a family history of bipolar, do not treat your patient or do not take you as living with a condition. Antidepressants alone in bipolar depression, not very good efficacy. Onset before age 25, again, that suggests bipolar depression. And then mild symptoms. So this is, you don't need to read the whole thing here. Let me summarize it. Many times when we make recommendations about treatments with bipolar disorder, those recommendations are made in committee, which is not 100% scientific. This is what the experts think. I wouldn't dismiss the experts, but it's not an exact science. So there's a society, International Society for Bipolar Disorders, I'm a member. And so we reviewed the question, should antidepressants be used in bipolar disorder? And the consensus was not on monotherapy. Number one, they don't work and they can cause mania. But it is fine to use some of them in combination, especially with the atypical antipsychotics. And in fact, that's where you find a very good response. Now, another thing that happens quite often is that, let's say you are a provider and you get a patient, and then the patient is taking different medications, and then you think you're too good, and you say the other people didn't know what they were doing. So one has to be very careful. Let's say I see a patient with bipolar disorder who's taking an antidepressant and an antipsychotic, and then I say, well, they shouldn't be an antidepressant, and I stop the antidepressant. That's a mistake, because then you put the patient at risk of relapsing. So if you're going to stop it, it has to be done, as I like to say, poco a poco, slowly, because abrupt discontinuation can lead into problems. So the consensus was not contraindicated, but do not use them in monotherapy and do not discontinue them abruptly. So these are the approved indications by the FDA. None of the older antidepressants, monotherapy, or the new antidepressants have been approved for bipolar depression. Lithium, in 1949, there was not the same system. So once the drug is not under the company, they won't invest. So you're not going to get it in the label because the studies are not done. Then you have lamotrigine. I've mentioned it before, and it does have the indication, but it does not have the indication for acute bipolar depression, only for maintenance. And as olanzapine fluoxetine disclosure, I designed those studies. Actually, it was the first medication that received FDA approval for bipolar depression. The problem is, of course, the tolerance of olanzapine, weight gain, and so on. But the efficacy was good. Quetiapine also has the indication by the FDA. Not as much weight gain as with olanzapine, but it does have side effects. And lurasidone. So lurasidone, it was really a new medication because it was the first atypical with a good tolerance that show efficacy in bipolar depression, and it was approved by the FDA. Valpret, there's some studies, it does not have the FDA approval, and sometimes that has to do because the studies were not that rigorous or the numbers were small. But you can see with Valpret, one positive study, and then in bipolar 1, but then in bipolar 2, no. Bipolar 2 appears to be more difficult to treat. And again, as a reminder, bipolar 2 is when you have depressions and hypomanias. But for the treatment of those depression, it tends to respond to a lower extent than bipolar 1. So this is, again, the treatments of depression. When you see this, crossing this red line, that's the confidence interval. That doesn't mean it's significant. So when you see it, these are the ones that they show statistical significance in bipolar depression. And as you can see, olanzapine, fluoxetine, again, disclosure, I was involved in that study. Lurasidone that we've mentioned, and then the newer ones is cariprazine, and then lamotrigine. There were a number of other studies, and I'll mention another medication in a moment, which is, let's see, here are the ones. So you have aripiprazole didn't show significance. Cariprazine did. Lurasidone, as we mentioned, did. Olanzapine, quetiapine, and cyprosidone did not. Why I say did not? Because if it crosses one, that means it's not significant. Newer molecules, that after lurasidone, there's something great about lurasidone. It's available generic. That's when I talk with the residents and they want to give medication X. Of course, I have to ask them, can the patient afford it? Does the patient have insurance? Because if they can't buy the medication, they're not going to take it. So this is the value of lurasidone. Of the new atypicals, it is the only one that is available generic. This is cariprazine. Cariprazine is also an interesting medication. It's user friendly. It's just basically 2 doses, 1.5 or 3. And interestingly, the 1.5 appears to be better. Well, better tolerated is not surprising, but even in some cases, better response. And actually, there's some study that show that it might improve cognition. This is as you can see, concentration, and that is mostly with the 1.5 rather than the 3. Now, it's not perfect. There's not a perfect drug. The most common side effect is akathisia, which is restlessness. And as you can see, it's dose dependent. It's more likely to have akathisia in 3 milligrams as opposed to 1.5 milligrams. But it is having akathisia as opposed to weight gain and diabetes and hyperlipidemia like olanzapine and quetiapine. You could argue from the point of view of tolerance, the newer drugs are better. And this is the newer drug. It's an interesting medication because it has a new mechanism of action. It's approved by the FDA. There's no studies yet. I understand they're conducting one for maintenance. So it only has acute bipolar depression. Same with cariprazine, and just for the acute phase. It's also user-friendly, 42 milligrams, and that's it. And it's well tolerated. So, and here are the results. Now, what about mixed features? In mixed features, of course, you need a medication that treats both symptoms. And as you can see, some of the drugs that seem to work well are olanzapine and asenapine. There's other treatment that we sometimes forget, which is the long-acting intramuscular medication. And that's an injection which is once a month, or sometimes as long as once every 6 months. Those medications can be helpful. The problem is that none of them prevent depression. The ones that are available are paliperidone, risperidone, and aripiprazole. They prevent mania, but they don't prevent depression. So to summarize, it's high prevalence. It can be lethal, and very frequently it's misdiagnosed. It also is associated with lethal outcomes. Antidepressants may be effective in combination with an atypical, but in monotherapy they're not, and they're overuse. And again, it can cause mixed features. Most treatments are better in protecting from mania as opposed to protecting from depression. And lamotrigine is an exception. That is the one drug that prevents depression, and it does not prevent mania. Lithium, it's not marketed because there's no profit, so it's underutilized. So we should not forget about lithium. The other concern that I sometimes have with lithium is adherence. So when you have someone who frequently stops the medication and abruptly, lithium, you have abrupt discontinuation that leads to a relapse. So you have to be very choosy in terms of when lithium is the best use. And then there's other new treatments, neurostimulation. Actually, we were doing a study at UNM with Dr. Quinn with TMS for bipolar depression, and also ketamine. As we know, ketamine helps with depression and also can help with bipolar depression. So let me stop there. And Mr. Stark is going to be managing questions and comments or criticisms.
Well, thank you very much, Dr. Tohen. And let me open it up for questions. And for the audience's sake, you might want to stop sharing your screen so people can. Thank you. You're welcome to raise your hand and ask a question, or if you're more comfortable putting it in the chat, please put it in the chat, and I will relay the question to Dr. Tohen. While people are coming up with their questions, I wanted to ask you, Dr. Tohen, a little bit more about a comment you made about interviewing family members about experience and past history. And I was just curious if you could say a little bit more about how you integrate family members into the treatment that you provide patients at your clinic.
Yes. So we believe in a collaborative approach. That means that I am, let's say, the expert in terms of knowledge of treatments or diagnosis, but I'm not an expert on what is best for the individual who I have in front of me. So in the first visit, in fact, if somebody's wants to see me for the first time, I would mention it's important that you bring a significant other with you. And most of the time they do. And then I explain them why. Of course, there are issues that are private. And again, sometimes patients, when they have an episode, they behave in a way that can cause a lot of damage. So one has to be careful with confidentiality. But I just mentioned what I mentioned before in terms of I need objective information and subjective. You who lives with the condition will provide me with the subjective information. How do you feel your mood is or your energy level is? Your significant other will provide me the objective. And I always ask, are they their usual self or not? And sometimes the individual living with bipolar may think that it is their usual self, but it's not. So that's the importance. And I tell them that will enable me to provide you with better treatment. So it's a collaborative care. And of course, what I usually do, I meet with the patient alone. And then, of course, we have other visits that is with significant others. And another key thing for me is that if there is an emergency, it's important for me to know that the individual living with the condition will give permission to the significant other to call me. So it's because it can be a life-saving. So I just explain why it's important. And of course, there will be things that are private and that's only between the patient and I.
Thank you very much. Now we have a few questions in the chat, and I'll read the first one. How common is bipolar diagnosis in youth? I'm seeing more young youth under 12 with diagnoses.
Sure. So again, it depends on how you define youth. The majority of patients develop symptoms when late teenage years. But the question is less than 12. And there's been a lot of discussion. I've seen it, but it also has been, the diagnosis has been overused. And in many cases, it can be attention deficit or not related to bipolar disorder. But it can be diagnosed as young as 6, 7 years old. Not in all cases, but it can. And I think a key here is family history. If there's a family history of bipolar and impulsivity, of course, sometimes it can look like mania or depression. So it can be diagnosed as in younger age, but it's a topic of debate where usually in the Americas there's the diagnosis is used more often than in the European countries.
Thank you very much. The next question. Are they finding that psych meds can cause dementia? If bipolar 1,
Uh-huh.
do you need to take other meds with lamicetal to mania since considered mood stable for mania since considered a mood stabilizer?
Yeah. Well, I cannot tell you 100% that drugs cannot cause dementia. But I also cannot say that they do. The reason why now it's being diagnosed more is because in the past, and this applies both with schizophrenia and bipolar, and both the conditions can be treated with antipsychotics. In the past, patients with those conditions would not live long enough to show symptoms of dementia. And in fact, you see the onset of dementia seems to be at a younger age than the general population. But the question is, can the drugs cause dementia? There is no evidence that they do, but there's also no evidence that they do not. So there's no evidence that they do. I would say that. But also, you need positive and negative studies.
Thank
It's
you.
inconclusive. Now, there's also, if I may add something here. I mentioned lithium. I was actually cheering for lithium, but the data is very good that if it's used more than 30 years, it can cause kidney damage. So it's not, unfortunately, perfect. So that's something that we need to let our patients know, that you're working well with these drugs, but it's not free of adverse events.
Oh,
And actually, some of the drugs appear to improve cognition, and actually including lithium and the others. Sorry to interrupt you, Mr. Stark. So it's many of the questions that it's not going to be possible to give a precise answer.
excellent. Thank you very much. Next question. My family member has many of the risk factors you described, family history, depression, etc. Is the clinic / your practice accepting patients?
So there's UNM. I represent UNM. I guess I look after the department. And I'm very proud to say that we just started a new service where it is called a walk-in clinic. And that means that anybody can walk in and receive treatment. And then not all of them are going to be treated there, but we will find treatment for them. So it's a new service. We just started it a month ago, and it's working, I think, quite well. So the answer is yes. We see everybody. We also like to see those who others don't want to see because they don't have insurance or because they're very difficult to treat. I think Ms. Clifford has an answer.
Yes. What is the name of that clinic? I think my son has been there, but
it's called the walk-in clinic.
I have not been able to accompany him, which I think is a great idea.
Yeah, it's just a month old. And in fact, it used to be on the second floor of the psychiatric center. And yesterday we moved it to the first floor. So we see a lot of patients.
Mm-hmm. He's been there in the last month.
Okay. Question, is there a phone number or some way somebody could find out about that clinic? Or we could send it out afterwards if need be.
Sure. Well, and actually, I have my email address here. It's my first initial and my last name, Tohen, @saludunm.edu. So if I get a message, I'll just probably won't answer the messages, all of them. I will just send them to those who can answer the questions. And actually, the walk-in clinic is now open just 2.5 hours a day. But so the plan is to extend the hours.
So that was your first initial, your last name, and at salud.unm.edu?
Yes, Mr. So.
Okay, I just put it in the chat for everyone. Uh, okay, I want to make sure I'm not missing anyone.
I think you missed one, Tom.
Sure,
A
go ahead,
little
Jess.
bit above.
Ask it.
Sure, I'm going to ask it. It's if the patient receives a once-a-month injection, does the patient need to take a concomitant antidepressant?
That's a very good question. Not necessarily, unless number one, there's symptoms of depression, unless that patient has a history of prone to have relapses into depression. So unfortunately, the available long-acting intramusculars, risperidone, paliperidone, and aripiprazole prevent manias, but they don't prevent depression. So that's a very good question. So it's the only time that I would give them monotherapy alone is if there is no history of depressive episodes or they're very rare. So then usually what we do is we add another treatment that could be, let me repeat, could be an antidepressant. I mentioned that they are contraindicated monotherapy, but this would be a good example where it can be helpful. The other one that I mentioned too is lamotrigine. It prevents depression, but doesn't prevent manias.
Thank you.
The advantage of the long-acting is that it's almost like an insurance. For different reasons, sometimes patients stop their meds abruptly. So you have this sort of like a life save, that injection that is there. So even the discontinuation of the other medication sort of prevents how hard the relapse is going to be. So it can be, it's not indicated for all, but it's something that we should consider.
Thank you. Okay, next question. Would someone with a mental illness like bipolar, for example, be more likely to later be diagnosed with a neurological illness?
The answer is yes. It could be a comorbid condition. So yes, in other words, suffering from bipolar disorder does not prevent a neurological condition. So
Thank
yeah,
you.
it's possible.
And then the next question, what suggestions do you have for prevention of bipolar disease if it runs in the family?
Well, that's a very good question for the following reason. When I take history and I ask, and the patient tells me, yes, I have relatives who suffer bipolar disorder, my immediate next question is, what treatment have they received and has it helped or not? So that's very valuable information. And if the patient tells me, my loved one is taking medication X, that's probably going to be my first choice, unless there's a contraindication.
Right, right. Another question, do you have any recommendations for working with kids over 14 who refuse all treatment?
Unfortunately, it's not unusual. I think teamwork is the way to go. It's sometimes it's very challenging. Many times there's no family around, so it has to be a multidisciplinary team.
Okay, thank you. Well, I think that exhausts our questions. I don't see any more. Let me thank you one more time for an outstanding.
There is one question. Sorry, Dan.
Go ahead, Jess. Oh, Dan. Go ahead.
Yeah, with your hand.
Okay.
I'm sorry,
yeah,
were you referring to me?
in a case where we have early onset, 14-year-old self-medicated with cannabis unsuccessfully for probably 10 years or so, finally correctly diagnosed bipolar, probably level 2 after incidents both on the manic side and on the depressive side. Uh, Family history. So what I'm trying to get at now is that once the patient is finally in treatment and seeing someone, but needing drugs that handle both ends of the spectrum, at this point, what should I be looking for in terms of the treating psychiatrist having tried or started with or settled on? You know, what handles or might be a good starting point to handle both mania and depression?
Well, that's of course an important question. So some medications are better to treat one or the other, and it may or may not apply for the recurrence. So in terms of the treatment, we need to consider both, and also other factors like non-adherence. So as I mentioned, I'm careful with lithium because it's stopped abruptly. It increases the risk of relapse. So it depends on different factors, and also when we provide treatment, is not only the acute phase but also the maintenance phase, and also make sure that there's no comorbidities such as um, recreational drugs and so on.
Yeah.
So we need to consider different treatments.
Right. So far, luckily, very compliant. Stays remaining sober, not mixing substances other than nicotine at this point, but off all other mood altering substances and compliant with taking drugs.
Well, I would feel optimistic about an individual that individual sounds that he's managing their condition the best way possible.
Okay.
Excellent. Well, Dr. Cohen, well, one last question. Is a multidisciplinary team available at the walk-in clinic that you mentioned?
It's actually one of the elements that treatment is multidisciplinary. It's a key element of the walk-in clinic.
Well, on that excellent point, I would like to close our meeting tonight. I want to thank everybody for attending. Dr. Tohen, I want to thank you for a great talk. And there will not be an info talk in May because May is going to be our NAMI fundraising walk that I mentioned before. And we are still working on securing a speaker in June, so stay tuned and we will let you know who our June speaker is going to be. And again, we thank you all for participating and wish everyone the best and a great evening. So thank you all very much.